Can you see me? Okay, yeah, cool.
So it's a great opportunity for us to hear from Jan about her dissertation research and future direction. So what we'll do is if there's a short clarifying question, you can feel free to interrupt and unmute yourself, but we'll mostly hold any substantive questions until the end. So thanks very much for coming.
Thank you, Jason, and thank you, Sherry, for organizing this presentation today. I'm Yan from Michigan State University, Sociology Department. I'm a PhD candidate in sociology. So it's very nice to have me in today's presentation. Before I formally give the talk, I'd like to introduce a little bit about my research interests. And generally speaking, I study medical sociology, but my research experience is interdisciplinary, including family demography, population health, aging and life course, gender and sexuality, and quantitative methodologies. And all my research relates to one topic, which is how people's social relationships can influence their health outcomes. And for the social relationships, I'm particularly interested in marital relationship, like relationships between spouses or partners. I also interested in sexual relationships, like I look at sexual activities and sexual satisfaction. And third one, I interested in intergenerational relationships. I particularly look at relationships between parents and children. And last, I also interested in social network in a broad concept like interactions with friends, relatives, and social activities. For the health outcomes, I'm particularly interested in mental health and cognitive health. So what I'm going to present today is the connection between intergenerational relationship and cognitive health. So my presentation today will focus on parenthood in later life and the risk of cognitive impairment. I will first talk about a brief background on this topic and introduce my conceptual framework. Then I will mainly focus on 3 empirical studies in my dissertation. And at last, I will talk about future directions and policy implications. And also, I will introduce a little bit of my other projects. So here is a brief background on why I'm interested in this topic. First of all, we are living in an aging society. By 2030, all the baby boomers will age to 65 and older. As the fast growth of aging population, dementia and cognitive impairment have emerged as rising public health concerns. And more studies have examined the causes or progressions of dementia, but they are predominantly focused on biological factors or behavioral factors. So the social determinants of dementia is not fully understood. And family relationship is one of the most important social relationships that people can have in later life. And demographic transitions has brought a lot of changes in family formation. For example, there are increasing number of childless people, step family, step parents, single parents, and same-sex parents. So parenting experience or parenthood history become more complex today. And it's important to know more about how this changing parenthood formation can influence parents' cognitive health. However, research on how family relationships can influence cognition in the US is very limited. And the studies specifically on how parenthood can influence parents' cognition is rare based on the US data. So my major question here is whether parenting experience relate to older people's cognitive health. Then I think about some specific questions, like I want to know whether parents can have better cognition than childless people, or rather having bad relationship with children can increase parents' cognitive decline. And I also wonder when people becoming parents matter or not to parents' cognition. Based on these questions, I'm trying to capture comprehensive aspects of parenthood, including both the stature and the dynamic of the parenting experience. So here is how I conceptualize parenthood. I include 3 aspects of parenthood, including parental stature, relationship quality between parents and children, and fertility history. I examine how each aspect can relate to older people's cognitive health. So the next question is why I expect these aspects of parenthood can link to cognitive health, or in other words, how parenthood can impact parents' cognition. Here I list 3 potential pathways to justify my hypothesis. First, parenthood may benefit cognition because children may provide economic resources to parents, like purchase medical services, good insurance, and children's income can increase family wealth. And that all can be protective factors to parents' cognitive health. And second, parenting can link to cognition through some social psychological factors. For example, children give parents emotional support, social support, or caring, but parental strengths, like having conflict with children or having demanding children, can increase parents' stress or depression, then harm parents' cognitive health. And last, parenthood can influence parents' cognition through some health behavioral factors or lifestyles. For example, like children help monitor parents' health behaviors, like regular exercise, diet, reducing heavy drinking and smoking, so that improve parents' health overall, including cognitive health. So here I'm explaining why I expect that parenthood can link to parents' cognition, but because of the time limitation, I won't talk much about the pathways. And today's presentation will just focus on 3 empirical studies examining the main effects of these 3 aspects of parenthood and how they can influence parents' cognitive health. And in each study, I adjust the effects of confounding factors, such like socioeconomic information. So next, I will talk about the studies one by one. The first study examines the association between parental stature and the risk of cognitive impairment. I first compare parents versus the childless people to see if childless people are more vulnerable than parents. Then I test, compared to childless people, if number of children, children's gender, and the biological relationship with children matter or not to parents' cognition. The outcome variable is a binary cognitive stature, including normal cognition as a reference versus people who have cognitive impairment. The data I use is the National Health and Aging Trends Study from 2011 to 2019. NHAS data is a longitudinal data with a national representative sample of older adults aged 65 and older. And data collection was conducted annually with in-person interview. So there are 9 waves in total. And the 2019 is the newly released wave. The overall response rate is 71% at baseline. After dropping all the missings, the final sample includes over 7,000 respondents aged 65 and older. And parents in the final sample all have adult children aged 20 and older. I used a discrete time hazard model. I first create person period files and then estimate logistic regression models to predict the risk of cognitive impairment. I use this method because I assume cognitive decline is a persist fixed state that people do not come back from. So it's important to use a discrete time hazard model rather than a simple logistic regression. Measures of cognitive function in enhanced data include both self-report data from a performance-based test. And for those who were unable to do the test, their cognitive status was reported by proxies, like their spouses or children. The self-report cognition was measured by three key domains, including memory, orientation, and executive function. For example, memory was measured by immediate and delayed word recall. Orientation was measured by whether the respondents can answer like today's date, month, year, or whether they can name the president and vice president. Executive function was measured by a test of clock drawing. So following the previous studies, the cognition impairment was measured by have impairment at least one domain. For respondents who were unable to complete the cognitive test, cognitive status was measured by the proxies report of Alzheimer's disease diagnosis or their responses to ascertained dementia 8, which is like 8 questions assessing early memory loss, orientation, judgment, and function. So the proxy reported respondents had diagnosed as Alzheimer's diseases or meet this ascertained dementia 8 criteria, then the respondents were classified as having cognitive impairment. Regarding the parental status, I include 4 variables. I first created a binary status, including parents versus childless. This is based on children's number. Parents are those who have at least one living child, including both biological and stepchildren. And the childless people means have no children. But unfortunately, there is no information indicating why the respondents become childless. So we don't know much about the heterogeneity of the childless people. The second measure is number of children as a categorical variable, using childless as a reference group compared to parents who had 1, 2, 3, and 4 kids. And third one is children's gender. I also include childless people and also parents who have sons only, who have daughters only, and parents who have both sons and daughters. The last one is the biological relationships with children, including childless people and parents who have biological kids only, having step kids only, and parents who have both biological and step kids. I also controlled for older adults' gender, age, race and ethnicity, education, nativity, marital status, and an indicator of proxy report or self-report. Here are some descriptive statistics of key variables. We see first here, 90% of respondents have normal cognition, but about 10% reported having cognitive impairment. And second, there are 91% of respondents have at least one child, but 9% are childless people. The third one shows number of children, and we see parents who have 1 kid, 2 kids, 3 and 4 more kids are kind of like evenly distributed. And in terms of children's gender, we see a majority of parents has both sons and daughters, but a smaller group of parents only have sons or only have daughters. At last, we see most respondents in the sample only have biological kids. There are only 2% of respondents have step kids only, and 11% have both. Here is the model result from a discrete time hazard model showing the association between parental status variables and the parent's risk of cognitive impairments. And I report odds ratios here. Please notice that in all the models, the comparison groups are childless people. In the first model, we can see the odds ratio here is 0.81 and significant at 0.5 level, indicating that compared to childless people, parents who have at least one kid show 19% lower odds of cognitive impairment. In model 2, we see parents who had 3 kids and parents who have 4 and more kids show lower risk of cognitive impairment compared to childless people. And in model 3, also compared to childless people, parents who only have daughters and parents who have both sons and daughters show lower odds of cognitive impairment. But interestingly, there is no difference between parents who have sons only and childless people. And in model 4, we see parents who have biological children only and have both biological children and stepchildren show lower risk of cognitive impairment. So basically, only having step kids doesn't show difference with childless people. A quick summary of the first study here. First, compared to childless older adults, older parents who have adult children show lower risk of cognitive impairment. And second, compared to childless people, parents who have 3 and more kids, who have daughters, who have biological children, show lower risk of cognitive impairment. These evidence are consistent with previous findings showing the vulnerability of childless people. For example, some studies find aging without children is associated with higher mortality rates or a higher risk of chronic diseases. And the positive effects of having children may result from children's support, either financial support or emotional support. So like having more kids means more support, and children can share the obligations of caring with siblings. However, there is not a lot of literature on how having daughters can benefit parents' health. But it is true that in most US families, the primary caregivers are adult daughters. So it's likely that parents have a better cognition because of daughters' care and daughters' frequent visits. And last, the first study also find that benefits of being parents may only apply to parents who have biological kids. And this might be because step parents may have more parental strengths with the stepchildren. But we have to notice that there is only 2% of parents who only have stepkids in the sample. So it's probably because the small sample size. From the first study, I examined the status of parenthood, and I explained that having children benefits parents' cognition because of children's support or caring. However, not all the relationship can go well. Some parents may have conflict with children, such like breaking up with children or having demanding children, or just no contact with children for different reasons. And a lot of literature out there has found negative relationship can be a stressor that increase parents' depression and trigger parents' health problems. So in the second study, I asked whether the relationship quality can link to parents' cognitive health. And I measure the quality of relationship between parents and children using relationship support and relationship strength with children and contact frequency with children. The cognition is measured by a continuous cognitive score, ranges from 0 to 27. So higher score means higher functioning. The data is from the health and retirement study, the HRS data from 2006 to 2016. HRS is also a longitudinal data. It's a national representative survey, and HRS collects data every 2 years. So there are 6 waves in total during the 10 years follow-up. An advantage of HRS data is the high response rate, more than 80% responses in each wave. After data cleaning, the final sample includes about 11,000 parents who aged 50 and older, and the oldest age is 104 years old at baseline. I grouped 6 waves of data into 3 time points. I do this because the relationship quality variables are in the Left Behind questionnaire, which means a half sample participated in 2006 and another half of sample participated in 2008. So the baseline here is a combination of sample from 2006 and 2008. And the second time point, the third time point, also the combination of like 2 waves of data. I think this is a little bit confusing, but I can explain more about it if you have questions. In order to analyze the trajectories of change in cognition over time, I used a latent growth curve model with maximum likelihood estimation in structural equation model. The cognition measures in the second study is from the self-report cognitive scores. HRS assessed the cognitive function using a modified version of the telephone interview for cognitive status. There are measures of memory, like the first study is immediate and delayed words recall, and also measures of attention, which is 5 trills of serial sevens, and also backward counting. The final score is a total score of these 3 groups of measures, ranges from 0 to 27. So like lower score means more impairment in cognition, and higher score means higher functioning. For each relationship quality factor, there are several items to measure them. For example, relationship support was measured by 3 questions. Parents evaluate how much their children really understand them, how much they can rely on children, and how much they can open up to children. Relationship strengths were measured by how much children criticize parents, how much children let them down, or how much children get on their nerves, or how often children make too many demands on parents. And the last, the contact frequency was measured by how often parents meet up with children and how often they speak on the phone with children. For all the 3 relationship quality variables here, the higher score indicate more support, more strength, and more contact with children. I also controlled for parents' gender, age, race, education, household income, marital status, and an indicator of survey year. In this page, I'm going to show a diagram of the latent growth curve model. I create 2 latent variables. One is cognition intercept, representing the initial cognition level. Another is the linear cognition slope, representing growth trajectories of cognition during the 10 years follow-up. And in this model, cognition intercept and slope were regressed on relationship support, relationship strength, and contact frequency at baseline. And cognition scores at each time point are loaded on two latent factors. So intercept factor and slope factors right here. The results here, the red numbers, showing how three relationship quality variables associated with the initial cognitive level. Specifically, we see relationship strength is associated with lower initial cognition level, but higher contact frequency with children is associated with higher initial cognition level. But relationship support at baseline doesn't have a significant effect on cognition intercept. The gray numbers here show the coefficients of how relationship quality can be associated with cognition slope. But we see all these three variables have no significant effect on the growth rate of cognition changes. So a short interpretation here is relationship qualities between parents and children only influence the parent's initial cognitive level, but do not predict the trajectories of change in cognition over time. In conclusion, the second study find evidence that contact with children more frequently is associated with higher initial cognition level. And this result is consistent with the studies on social contact and risk of dementia. And these studies show a protective effect of social contact against the dementia because frequent contact confers higher cognition reserve. Second, I find a negative effect of relationship strain on parents' initial cognition level. This is consistent with previous literature on other relationship qualities that negative effects from a bad relationship may have a stronger effect on well-being than the positive effect from a good relationship. The third study focuses on another missing puzzle piece of parenthood, the fertility history. This is from my question on whether the timing of parenthood matters to parents' cognition in later life. Timing is one of the most important principles in the life course approach. Both men and women are expected to become parents at a typical age or having an on-time fertility. So the first measure of fertility history in the third study is aging at first birth or timing at first birth. The second measure is number of biological kids. I ask whether high parity births or low parity births can have impact on parents' cognition. You probably noticed that in the first study, I've already tested the effects of number of children, but the difference here is I only focus on parents who have biological kids here. The cognition is a binary cognitive status, including normal cognition versus cognitive impairment. Like the second study, the data I use here is also from HRS. Fertility history data is from the HRS family data from 2000 to 2014, and there are 8 waves in total. The final sample includes over 10,000 parents aged 50 and older who have biological kids only. And the age in the final sample ranges from 50 to 94 I also use a discrete time hazard model to estimate the risk of cognitive impairment. The third study also includes both self-report and proxy-report cognitive status. Like the second study, the self-report cognition includes words recall, 5 trills of series sevens, and backwards counting. I classify the scores into a binary cognitive status. This is follow the previous studies. So like 10 to 11 means having cognitive impairment, and 12 to 27 means having normal cognition. The proxy reports are the proxy's assessment on whether the respondents have memory loss or having limitation in daily activities or having difficulty completing the interview because of cognitive limitations. Also following the previous studies, the cutoff point here is from 0 to 2 as normal cognition, from 3 to 11 as cognitive impairment. The timing of fertility was measured by a continuous age at first birth, because there is no direct measure for the age at first birth in HRS data. So I created a variable using parents' current age minus age of their oldest kid. This graph shows a histogram of age at first birth for both men and women. And the y-axis is the percent. And we see the age at first birth ranges from 10 to 63, and the mean age at first birth is 24. Based on this continuous age at first birth, I created a categorical timing of first birth. This is defined by the highest and the lowest quartiles of the distribution. The typical age at first birth, typical timing, is from 21 to 27. And I define early timing of first birth from 10 to 20, and delayed timing from 28 to 35. And older than, 28 to 35. And older than 36 is very delayed timing of first birth. Number of biological kids also includes both continuous and categorical measures. The right graph shows a continuous number of biological kids. We can see it ranges from 1 to 19 kids, and the average is 3 kids. In the categorical number of biological kids, I use having 1 biological kids as a comparison group versus parents who have like 2, 3, 4, and more kids. This is the result from the discrete time hazard model. I also reported the odds ratio here. We see Model 1 shows the relationship between a continuous age at first birth and parents' risk of cognitive impairment. And the age at first birth here is centered. We can see the odds ratio here is 0.95, indicating that each 1 year increase above the mean age at first birth is associated with 5% lower odds of cognitive impairment. So basically, it says the older, the better. In terms of the categorical timing of first birth, we see in Model 2, compared to parents who gave birth in a typical age, like 21 to 27, parents who give an early first birth show a 11% higher odds of cognitive impairment. But 2 groups of delayed first births do not show difference with on-time group. Regarding number of biological kids in Model 3, we see giving more birth or like having more biological kids is associated with a lower risk of cognitive impairment. Also in model 4, it indicates parents who have 3 biological kids show lower risk than those have only 1 biological kid. Here are graphs showing how age at first birth or number of biological children predicting cognitive impairment. The left graph, in the left graph, the x-axis is continuous age at first birth. And the y-axis is the predicted probabilities of cognitive impairment. We see this line goes down when parents' age at first birth goes larger, indicating the older age at first birth, predicting a lower probability of cognitive impairment. In the red graph, the x-axis is the continuous number of biological kids, and the y-axis is also the probability of cognitive impairment. As the number of biological kids increases, the probability of cognitive impairment decreases. The third study find evidence that the older age at first birth, the better cognition, and early fertility timing increases the risk of cognitive impairment in later life. These results are consistent with previous studies showing the early fertility may increase people's risk of health problems in middle life or in later life, especially for mothers. And this association is very likely because of the less privileged status among people who had early first birth, such like lower education or lower socioeconomic status. But parents who had on-time or delayed fertility timing may have a longer time in school or with better social status. Also, the third study find having more biological kids or like high parity births is an indicator of better cognition. Actually, previous studies on number of children and parental health show very inconsistent evidence. On one hand, having more kids means there are more support from children in later life. But on the other hand, having more kids may dissolve parents' economic resources or increase demands. But we see this third study didn't find that having more biological kids damage parents' cognition. All right, here is a quick summary of 3 studies. So what factors related to parenthood may confer parents' cognitive health? I find having adult children, especially daughters, having 3 and more children or having more contact with children are all likely to benefit parents' cognition in later life. However, being childless, experiencing relationship strengths with children, or having early fertility timing are all associated with higher risk of cognitive impairment. These studies have several limitations and also indicates some future directions I can do to make the argument clear. First of all, the measure of cognition is based on performance cognitive test or praxis report, rather than the clinical diagnosis like the MRI results. So this performance-based test may have issues of misclassification. Also, like I mentioned, there is a data limitation on defining the childless people. People remain childless for different reasons in later life. Some childlessness is by choice, but some are because of like infertility or death of children. So I think future studies can figure out how these different pathways to be childless in later life can make a difference on parents' cognitive health. Secondly, there could be selection effects in the studies. For example, people who have lower risk of cognitive impairment or lower risk of dementia were more likely to be selected into parenthood or more likely to have more kids. And I think there are more sensitivity tests that can be done in the future. Thirdly, I plan to test some moderating effects, including older adults' gender, race, and marital status. I actually tested gender interactions through all the 3 studies, but surprisingly, there is no gender difference between men and women in each study. So I think future research can use like different data sets to test if this is robust or not. And another important perspective is to investigate the racial variations. I wonder if this relationship between parenthood and cognition can be stronger or less stronger among racial minorities. And I'm also very interested in testing whether this association can vary by parents' marital status, because for divorced and widowed parents who lost the support from spouse or partner, children's support may be particularly important in their lives. And those who are both childless and unmarried could be the most vulnerable population. And the last point is, I think my next step is going to test the different mechanisms that can link parenthood and cognitive health. Like I talked about at the very beginning, I wonder if parenthood influences cognition through economic resources or social psychological factors or health behavioral factors or lifestyle factors. So in a nutshell, these 3 studies suggest that parenthood is a potentially important but understudied social protective factor or social risk factor for parents' cognitive health. And we know that the number of childless people and step families are growing in the US. So it's important to further explore the complex life course characteristics of parental status or parenthood history, because this might contribute to the risk of dementia or risk of cognitive impairment. And the healthcare system, the federal government and local community or just like policymakers can think about more effective interventions to support vulnerable older adults so that reduce these effects of risks. And these studies also indicate that the linked lives of parents and children remain a very important influence on older parents' cognitive health. And previously, interventions have often overlooked the negative consequences of relationships on well-being. But these studies highlighted the strong effect of relationship strengths on parents' cognition. And I think practitioners can help older adults identify potential sources of conflict or tension in intergenerational relationships, like discussing different expectations and the social norms that parents and their children hold. And these are almost everything for today's presentation. And then last, I want to talk a little bit about other project related to cognitive health. So the first project is my advisor's funded project, focusing on the linkage between marriage and Alzheimer's diseases and related dementia. We examine how marital status, marital quality, and the marital biography or like marital transitions can link to the risk of ADRD among older adults. and we have several papers in progress and published. Another project related to cognitive health is the study focusing on social integration and cognition. I lead this collaborative project, and we examine the social relationships in a broad concept, including not just the family relationships, but also network outside family, such like interaction with friends or participation in social activities, like religious services. And we investigate the racial variations in this project. Besides cognition studies, I also had some research experience in sexuality, sexual relationships, and gender ideology and mental health. So if you're interested in any of this, I'm happy to talk in person or in the email. Thank you. Thank you for having me, and thank you for your time. I'm happy to answer any questions you have.
Thank you so much. That was a spectacular presentation. Let's just try to have people ask questions as they come to them. Maybe I'll just start out with a conceptual question as other people are thinking about their own questions, which is that you showed us a lot of interesting findings that in some cases examined the measures of cognition trajectories, and in other cases, so it was like a continuous measure and it can change over time. And in other cases, there were these thresholds where you have some dysfunction or limitation, and so it was a 0-1 absorbing state. So I wonder, my question, the conceptual question is how you think about making the decision of how to model, how to make that choice, because it seems like your data is always allowing either choice to be made in these analyses. Is that right?
Yes, that's a very great question. I think for the study 1 and study 3, I used the discrete time hazard model, and the outcome variable is like binary, like 0 and 1. And the second study is like a continuous score of cognition. I think for the cognition or dementia studies, it's similar to like mortality studies. In a lot of literatures, I saw people use this like survival analysis or hazard models because the natures of like having dementia or not having dementia. But in the second study, I want to see if there's like influence on the trajectories of changes in cognition. And I think my next step is can test to use like a latent growth curve model with a binary outcome of cognition. I think that's a good point to do some like a robust test or use the latent growth curve model to like combine with like hazard model to see whether I can have like consistent results with this using this like continuous score. I think there's just like different ways to test if the result is robust. Does it answer your question? Sorry.
Yeah, that's excellent. Thank you. Boyan has his hand up.
Sure.
Yeah, thank you very much for your talk. I have, I think, 3 questions, I think.
Sure.
So for the first question, for your third research, I think you include both men and women in your analysis, right?
Yeah.
And you mentioned that there is no gender differences in the effects of fertility history on their cognitive health.
Yeah.
Yeah, well, that is, well, I think that is kind of surprising because fertility means so different things for men and women. And I don't know if, probably some, I would think that there will be gender differences, and I don't know if some alternative modeling will reveal that. That is just my comment. And another question is that you use the number of children, a categorical number of children in your first and third research. But But to be honest, when I read your table results, I do not think that the coefficients are really different by the number of children. Like having 2 children, have 1 children, 2 children, 3 children, 4 children, although the significance differ to each other, but I think their coefficients are really similar, and so do the standard errors. So I think you may want to check if, say, changing from a binary category of childless is really different from the 1, 2, 3 or more kids. So probably I suggest that I think as you use a discrete loaded model, you can use log likelihood ratio test to test if, say, adding these categories really improve the model fit. So probably just include a binary variable will be the best choice. Yeah. And I think the third question is regarding the second study regarding the I think the reverse causality issues, because I think that the fertility is reasonably before the like the aging period. But for the second study, I mean, I think there is a likelihood of reverse causality that it is probably the parental cognitive ability will increase the strength between child and parental relationship as well. Yeah.
Yep.
So I think probably reverse causality may be considered.
Yep.
Yeah, I think they are my comments. I mean, thank you very much.
Thank you. I think all 3 questions are very good points. First, for the gender differences, I think it's also surprising that there's no gender difference in all the 3 studies, and I used 2 different data sets, and there's no gender difference. And this is particularly interesting in the third study, like you said. Fertility history can mean very differently for men and women, right? And I think the timing of fertility, especially for women, and I see previous literatures on this topic only focus on women sample. I feel like I don't remember like there's a literature on both men and women. We're just focused on men. So all the literature is just on women. So I think in future studies, I can like separate man and woman sample to like test them separately to see if there's like some interesting relationships. And also I think future studies, I can use like different data sets to test if there's a gender difference. And secondly, the number of children. I think you're right. I think the third study, let me quickly show. So your point is the pattern here is like having 2 kids, 3 kids, and more kids actually show the same pattern. Like no matter how many kids you have, the process of children show a lower risk of cognitive impairment. Is that?
Yes. Yes, yeah. I think because the standard errors are the same and the coefficients are close to each other in terms of absolute sizes. And I think the same thing holds for the first study as well. So I guess, yeah.
I think that's a good point because like having kids or not maybe matter more than how many kids you have, right? Yeah. And the third question is also a very good point. In the second study, so your question is if there are like a reverse relationship from cognition to relationship quality. For example, like the changes in cognition probably can predict the changes in relationship between parents and children, right? So actually, in the growth curve model, I test if there is like reciprocity relationships from cognition to relationship quality, but I didn't find significant results. Actually, this is consistent with some previous studies using HRS data, probably just because the HRS data, but or probably because the observation time, like 10 years, is not long enough or maybe the sample size. I think if we have like a longer observation, like more survey years, there probably some interesting results. Yeah, but that's a very good point. Yeah, yeah.
Michal, do you want to ask a question and then maybe go to Grace?
Sure. Yeah. Thanks for your presentation. I wanted to follow up, actually, I think a little bit on the point that Boyan raised on the gender differences and how you think about that in conjunction with the biological versus non-biological children, right? So I think in the first study and the third study, you included an indicator for whether children were biological, but not in the second one. And yet it seems like when you're talking about mechanisms and pathways that may be related to the impact of having children, right, of basically realized fertility on cognition, you're really emphasizing the social mechanisms, right, the relationships and the social support. And so I wonder how you think about that and how you reconcile sort of the varying emphases on the biological versus social links here.
Yeah. That's also a very good point, because as a sociologist, I think we kind of like assume that we work on the biological, the social factors or social mechanisms, and sometimes ignore like physical mechanisms. And I think definitely, like I said, in the third study, I can test if for example, like fertility timing can be different to like separate men and women sample to see whether there's different results, like how fertility timing show like different gender patterns. And I think in the second study, in terms of like the relationship quality between parents and children, in my reading of previous literatures, this relationship quality probably matter more to women's mental health or well-being. And even though I don't have like gender differences, interesting results, but I think from the previous literatures, this relationship quality probably matter more to women. And that's because the mechanism of like mental health, like relationship quality influence women's mental health and then influence the cognition. And for men, this mechanism is more like the health behavior, like relationship quality influence men's like lifestyle, like drinking, smoking, or like sleep or diet. And so the difference is for women, the mechanism is more like through mental health or mental mechanism, but for men is more like the health behavior.
So then what's your thought on why the biological indicator would matter at various points, right? If it's more about the relationships and the way in which they influence behaviors in later life, what do you think that sort of looking specifically at the biological nature of the relationship is capturing? Is it a biological mechanism, or is it sort of an indicator of like the closeness of a relationship because you're hypothesizing that like biological children would have a closer relationship? And is it that, yeah, like, are you thinking of things that are happening sort of very early in the life course that put people on a path to cognitive decline? Or are you thinking about these as things that are really manifesting in adulthood because of the nature of the relationship with the kids?
Yeah, I think some like social factors in our early life experience that definitely may have some like cumulative effects on people's like physical, mental health outcome in middle life or later life. And then that's maybe the factor influence like cognition reserve or then influence the risk of dementia or cognition. Yeah, cognitive impairment. Yeah.
So primarily a social mechanism, but maybe proxied by a biological relationship.
Yes, I think from my understanding, I think this pathway can be like from an early time social factor influence health in middle life or later life, and probably that's the reason influence cognition. Yeah.
Great, thank you.
Yeah, thank you. I hope that. Yeah.
May I maybe chime in on that, because my question relates to that. Thank you for this thought-provoking presentation. So I was actually interested in if you have any plans on how to disentangle what the effects are of parenthood earlier in, like, when parents become parents in the midlife, and then to disentangle that from when you are looking now when they're 65 years old and they have a good relation to their kids. So you were talking a lot about different mechanisms on how having kids at the moment of being, or at the age of 65, may be beneficial for later cognitive decline. But these people who are parents have been parents for at least 20 years in, like, the study designs. So how are you going to disentangle potential beneficial effects that they acquired in midlife? So let's say things like, I don't know, if you have a kid, you may have a more healthier lifestyle than people who don't have a kid, because you want to have a healthy lifestyle for your kids. So they may be, like, induced, so not confounded, but induced by becoming a parent. You may acquire some patterns that may be beneficial. And how would you want to disentangle how would you want to investigate what is actually this idea of the pathways that you're telling at the moment of being in their 60s? What is beneficial there, and, like, what have been effects that already happened 20 years ago, which is, like, a very sensitive time in their midlife for for their health factors, for example. Do you have any ideas how future studies could look into that?
Yeah, that's a great question. I think a way to figure out, like, is to do some age interactions, like, because my sample is, for example, like HRS is like 50 and older, and the age range is very wide, like from 50 to like more than 100 years old. I think I can divide people into like 50 to 60, 60 to 70, so different groups of age, and to see, like, different like compared to, like, the oldest old and to some, like, not very old older adults, to see what's the difference between like different age or different cohorts. And you also ask a question about, like, I think your question is about, like, how like selection effects, like from like some factors may influence the probability to be selected into parenthood. Is that your question early? No.
Sure. No, I think you answered my question.
Okay. Yeah. Sorry, I just
Thank
tried
you.
to capture all the questions you have. Yep. So. Okay.
Great. Thank you.
So we'll go to Gracie and then Leafia and then Ava. So Gracie's first.
Hi. First of all, thank you so much for your presentation and your time. This is fabulous. The subject matter is really interesting.
Thank you.
Appreciate it. I was really curious, particularly, I think, as it pertains to your first and your third study, if you considered cohort differences and how, like, social norms and also just, like, technological access to infertility treatments might have played a role, and what your thoughts on that was. This isn't my world, so
Okay.
very curious.
Thank you. That's also a very good question. I think my next step definitely can test the cohort difference. Like I said, like separate people into like younger age, like oldest old. And I think there's some like you said, the social norms factors. An interesting study I participated before is compare the same-sex people and different sex same-sex couples and different sex couples, and in the sample, like those same-sex people are in a younger age. So I think the composition of parenthood were like completely. I think like because the changes of like family formations, maybe the younger cohort may have like more complex parenthood history. That's just some like my assumption, but I think that's a very good point to see the cohort difference because the sample covers a very wide range of age. Yeah.
I look forward to reading your future findings.
Thank you.
Lipia.
Hi, Yan. Thanks for a really interesting talk. I was intrigued by a finding on the effect of having more kids or having any children on parents' cognitive health. And I was just trying to think about this, like you just kind of mentioned, the selection, potential selection into having more children. Specifically, I'm worried about this story that I've heard about how, for example, there are intergenerational correlations in fertility. So if you grew up in a family that's bigger, you have more siblings, you're more likely to want to have more children. So I'm just curious if you have like variables in your data set that can allow you to control for that, or if you've explored that. The other thing I was wondering about is personality, like selecting into having children. Are there personality effects on both fertility and cognitive health? Thank you.
Thank you. These 2 points are great points. I think in HRS, I probably can test like how big the family is, like how many siblings or how many children in total. That's something like available in HRS family data, and to see how like and also I think there's variables about like how the network size, and that probably a factor, like you said, influence people's norm on their ideology on marriage and parenthood, right? And that probably influence the probability slide into parenthood and marriage. And the second one is factor of personality, right? I'm thinking about some objective measures or available variables in the data can measure the personality. Because I feel like a personality that's kind of like a psychological area, and sociologists measure a lot more in like education or race and ethnicity, and that's probably can capture something about like personality or the norms or ideologies they have. Is that I feel like I don't know much about the personality variables, but I think I can indirectly measure something on this factor. Yeah. Thanks for your question.
David, do you have a question?
I do. Hi. Thank you for coming here virtually. So this is in relation to your first aim. And as others have been noting and thinking about the selection into having more children, it seems like a lot of the results from your first aim are driven by the individuals who have had 3 or more children. But your question is, well, at least the way that I understood it, was centered around, does having children improve later on cognitive health? And of course, you know, what's the relationship to the number of children? So I mean, I don't know, I don't study fertility and reasons for having children, but I am curious if you were to do almost a sensitivity analysis, and forgive me if you already mentioned this, but looking at just removing that group of people who have had a lot of children, I guess I don't know if 3 is considered a lot, but because if I remember correctly from your summary statistics, they didn't make up a huge portion of the sample, and just seeing does having children are your results still robust without that group? Because I think that group is potentially unique in ways that I don't know or that are not clear from socioeconomic status or education, and some of the effects that people have been talking about before. And so I'm really just curious about how that would affect your results, because the effect sizes for all of them were relatively similar. For having 1 child versus 2 versus 3 versus 4, it was just that having 3, 4 children or more really was where that's where your coefficient became significant.
Yeah, thank you. The short answer is no. I didn't do a test to like drop these parents who have a lot of kids. But I agree with you that there's a smaller sample size of parents who have a lot of children, like even like more than 5. That's a small proportion of parents in the sample. Yeah, I think I can do some sensitivity tests to just focus on like people have 1, 2, 3, or 4 kids, like drop this like a small group of parents who have a lot more kids to see if the result is robust. Like you can see the majority of parents in the sample have 2 or 3 kids. Yeah. Yeah, I think I answered your question.
I have a question. Go ahead, Natasha.
Okay. So as for the number of, as for the results of the first study and the number of children, and then you found effects that participants that had both sexes were also beneficial, had beneficial effects. Is that correct? If I remember
the first study?
Yeah, in the first study where you found that those who had
let me quickly come back to the first
sons
study.
and daughters were at an advantage, and those who had only one. I don't know what the comparison group was.
You mean this slides, right? Yeah.
Oh yeah. So you said, oh no, it's also daughters only. So it's daughters only, and okay, no, then this point is not relevant anymore. But I had another question.
Okay.
And that was, did you compare your, like, so you found some cross-sectional associations, and I also agree with comments made before about reverse causality with particularly these results. But you found some associations between having better relationship with your kids and better cognitive function, or less less likelihood of having decline, having impairment. How do these effects compare to the effects that you see on the quality of marital status? So I would be curious in like how important are the relationships to your kids, and how important are the relationships to your partner, and what would that tell us about the potential pathways that are going on in how potential beneficial effects would occur? Could you maybe give us some insight from the knowledge that you have on that?
Thank you. That's a good one. Yes, I also do some like my RE project is the marriage and cognition, and we also do studies on marital quality and cognitive health, and we find similar pattern that having like negative marital relationship can increase the risk of cognitive impairment, and good marriage may be a protective factor to older adults' cognition. I also, in the social interrogation and cognition study, which is in early stage, I tested both the family relationships and relationships outside family, and include variables like marital status, parenthood status, and other factors like social context with friends. And when I put marital status and parental status, these 2 factors in one model, and I find that there's no effects of parenthood status. And the marital status show a robust and consistent, strong effects to people's cognitive health. And I think for older adults who have a spouse and who are not living with children, or who maybe like have little contact with children, the spouse relationship is the most important factor that can influence their cognition, because the support from spouse.
Modification, basically.
Sorry.
There's also effect modification, and you looked into that.
Yeah. Yeah, that's also the reason why I want to test the marital status interaction to see whether like those who are divorced or widowed parents, the children's support can be particularly important to them. Yeah.
Yeah, I think there's quite some research on that with other social networks, like those people who are widowed or who are living alone are more likely to benefit, or yeah, I mean, I don't know if it's causal, but are more likely to show less health symptoms when they engage in social activities than those who have a partner and are not that potentially lonely. Yeah.
Thanks.
Thank everyone for the questions. Yen has a bunch of more meetings to do this afternoon, so I think we're going to give her a break. So I think we'll say goodbye if you'll stay on for just a minute and say goodbye to everyone else, and thank you for hanging out with us.
Thank you. I saw there's some questions or comments in the chatting box, but we're out of time. But if you feel interested in this research, feel free to contact me in email or like talk in person later. Yeah. Thank you very much. Thank you very much for your time and have a good weekend.